Welcome everybody to BlockHeads June of 2024. Excited to have everybody here. We're going to be discussing complications, and we're going to have a little bit of a peek at our recent look at the registry for nerve blocks with a multi-site registry. So I'm going to let Dr. Lachlan Driver take over, and then Dr. Tom Jelic will be discussing complications as well after that. Thanks, everybody.
Thank you so much for having me. Yep, I'm Lachlan Driver. I work at Mass General and Brigham, and I'm part of a part of the nerve study with Dr. Goldsmith and all the co-authors, some of whom are here as well. And I wanted to share a little bit about the registry and with a focus on the complications and adverse events that we've had. Um, in terms of the data collection, we collected from January to December, January 2023 to December 2020, 2022 to December 2023. We have a total of over 2,700 blocks that we've assessed now, over 11 national sites. Here are the sites sort of all over. Um, in terms of the most common blocks performed, I think none of us would be surprised that it's about a third are fascial or femoral nerve blocks. They sort of lump them together. And then, of course, we have erector spinae, forearm, serratus, transgluteal, interscalene, and some others. Some of the less common ones are, of course, raptor, for example, or stellate ganglion that were performed once. Just to very briefly talk about the challenges recorded and over the blocks, a lot of people cited patient movement, difficulty visualizing needle tip, or particularly in the residents, lots of vasculature in the area and sort of difficult to get the needle around that. Poor fascial spread, particularly in the fascial block, of course, and then difficult visualization in patient habitus, particularly large patient habitus, made it a little more challenging. Um, but to focus on the adverse events, there were 3 episodes of hoarseness that we experienced. So, typically due to potential unilateral laryngeal nerve blockade, this is in the supraclavicular brachial plexus, and that happened twice, and then once in the superficial cervical plexus. There was 1 episode of hyperventilation slash anxiety slash breathing difficulty after a transgluteal sciatic nerve block. Um, there were 3 episodes of difficulty walking, sprained ankle, and slash weakness, sort of all lumped together, where there's 1 episode of a sprained ankle after somebody left AED after transgluteal sciatic block, where they developed this, temporary foot drop, as we know, and then couldn't, drop their foot, twisted it, and went straight back to the ED. There was 1 episode of numbness from the lateral shin, again, an expected side effect, but the team did a subsequent MRI that showed a new malignancy at L4. And the third case was, I couldn't see any details, so it's unknown, but sort of a similar side effect. Um, there was 1 episode of hypotension after a fascial block. And like digging through it a little bit, the team thought it was more likely secondary to the bleeding due to the patient's fall. It could be due to the vagal response. They had negative aspiration throughout the procedure. They really did not think this was at all related to the block. Um, they had 1 episode of severe pain at nerve distribution after transgluteal, but ultimately the patient ended up leaving the AD. Notably, there were 0 episodes of significant bleeding, 0 arrhythmias or seizures, 0 compartment syndromes, 0 cases of infection, 0 cases of pneumothorax. But then, in terms of serious adverse events, we had 1 time over the 2,700 blocks where we used a partner site use intralipid due to possible last, and then 0 cases of peripheral nerve injury. Talking about that last, I spoke to the providers where this occurred. In retrospect, it's obviously always better to give intralipid early. However, in retrospect, they weren't sure if this is last versus the patient having severe anxiety that sort of presented itself similar to last. But given that intralipid was used, we sort of documented it as a case of last. But no peripheral nerve injury that we know of. So we evaluated this many blocks, and then we had one potential significant adverse event. Obviously, we're much better at catching the more proximal side effects than we are the distal ones. We evaluate these blocks at least 30 days after the block was performed when we import them, but it's still definitely possible that we missed, for example, a peripheral nerve injury if a patient went to a different site where we weren't able to kind of see it in the EMR. So, but just something that we want to keep in mind. That's about it.
Wow, that is some fantastic work. I'm gonna open it up for some questions. I just want to remind everyone that this is preliminary data. Please don't cite this for like, major effects or change or to other departments. This will eventually be published at that time of publication, and when it gets through all the processes, I think that's reasonable. At this time, this is just kind of like preliminary. Here's what we're seeing. And so I just kind of want to put that cautionary element out. Go ahead and questions away.
Can I start? Is that okay?
Yeah. Go ahead. Yeah. So we'll
that was
actually
fantastic
yeah,
and a massive undertaking to do this. So kudos to you guys and the team. Was this self-reported, or how did you guys like pull this data?
Oh yeah, absolutely. So it depends on the site. It's pulled by the site. So we had the 11 sites that are all kind of part of the registry. Essentially, yes. So every site, at least 30 days later, has to report at least 90% of their blocks for that period. And everyone has kind of varying ways of pulling it. Highland has like a more automatic system. I ended up just doing it manually. One by one, and then we had really a surprisingly good raw agreement when we went back and had a second reviewer take a look and just make sure that we're at least 90% on like us over, let's say, 10 random patients. But
at Hennepin, we are, I think, the only one that are doing it prospectively.
you guys are
So
right.
we were a little different.
I wish I could do it prospectively.
24 hour research assistants, that's how you do it.
This is Joe from University of Colorado, and I think that's kind of our plan for moving forward, is to try to mimic a little bit of what Andre and Hennepin are doing, but then I think the pivot for the future would be to transition from retrospective to prospective.
I was doing a fully prospective is that the 30-day mark makes it, to some extent, you need to wait for a delay in time, right? So it's going to be multiple instances sometimes. So the way we do it in an ideal world, the way I wanted to do it at Highland initially was that every 30 days we're updating the registry. Life is difficult to do that with this. So what ended up happening was we do batches of like 6 to 8 months at a time, just because it's hard to actually do the query. But I think the other sites, I think the one at Michigan, another site was using an Epic query that was even more automated than ours. But I think the goal should be trying to automate this as much as possible in terms of using our electronic medical resources to really kind of help us. So we've done a lot of different builds and actually help. This is kind of an ongoing QA project for the department in terms of now we have 30-minute notices after you actually do a nerve block. So as long as you drop the template, 30 minutes later, the nurse will get a prompt and gets this, like, they can ignore it, but it says, please document post-block score. And then that way we're trying to also avoid any sort of self-reporting. So we decided to do this actually before we even joined the registry. We really thought that it's very biased. There's a lot of provider bias. If you go back and ask the patient 30 minutes later, hey, how was your block? Like, a lot of times, even after the second after they finish, they're like, oh yeah, doctor, it's all better. I have no pain. I'm like, that's not realistic. But so I think that those are some of the ways we're mitigating the bias in the self-reporting, and I think improving also just the collection of data. So that's what I would encourage people to kind of figure out how to improve the electronic medical record to really kind of facilitate the collection of this data.
Absolutely. We also, I wish we're even more biased than that, because we don't have like a nursing protocol. So it ends up being provider. And, I feel like it's a lot, it's a system, it's a system issue where it's mostly me and some of the attendings being like, document your post block scores, because it's better, but also for research. But unfortunately, a lot of times it doesn't get done. So I think overall, I want to say, I can't remember the exact number. I think it's high 60% of all the blocks have documented pre and post scores in the registry. So it's not.
So I'm gonna hop in, Lachlan, for a second. So
Of course.
So as Arun, so this is the initial idea was really about just generating some data, right? Perfect data is bad data because it'll never happen. And the goal was to get something out. And I'm not saying that we should do crappy data, but we have to recognize that we have to look at this as a scalable process. So having every center find research assistants, finding perfect block scores, doing it's never going to happen. We're going to get to 2 sites. So the goal is to make a system that is simplified. And so what we've been doing, as David said very well at Highland, is trying to build systems that reduce provider error. So one is intrinsically after the block is done, there's always a nurse taking care of any patient after block is done. They have to be monitored for 30 minutes. That is a standard operating protocol, an SOP at Highland. In that 30-minute window, they get notified they have to put a pain score in. Does it happen all the time? Maybe it's happening 30% of the time, but the goal is to get it to 90% because then we have a system that constantly feeds this marginally better data. I think moving to perspective quickly is a bad idea. I think all it will do is have a lot of sites that can't do it and also make data collection really difficult. So I'm not saying that we should not look at that as an end term goal, but we should figure out steps, right? To me, which is about taking tiny steps each time to make it better and not trying to figure out the answer right away because that'll never happen.
Yeah, I agree. I think just at Hennepin, the only reason we did perspective is that's because in my situation, that's easier. I could not get Epic to switch procedure notes, which would have been automatic. I just work at a different place that I have 24-hour research assistants that I can just be like, go get this information live. But that's unusual and not external generalizable. It was just the easier path for us.
Right. So what I'm trying to say is the goal of this project, there's a ton of, I can look through every aspect of the project and find holes in the methodology. But the reason it'll get published is because of the strength of numbers. And so we have to recognize that there's an intrinsic bias in data collection. But if we clean that up, if we were just able to get data points, and Lachlan can correct me on this because I've now read this paper like 15 times on editing. If we get that number from 60% of reported pain scores post block at 30 minutes to 10%, it is a huge win. And then we can clean up the other stuff like self-reported events, right? Like then we could say, okay, let's have everybody look through each patient at 3 months and see if they have any events. The problem is at Highland, we're going to fall out because our patients don't come back in 3 months. Or maybe at Kaiser, this would be a perfect study. But so I think that we have to recognize the intrinsic limitations of numerous centers and try to find at least small steps that can be amended for the next version of the data collection that could reduce the problem. If we just move this to a bigger, amazing study, unless we're able to generate grant funding and hire research assistants at every site, we're never going to do everything perfectly and recognize the intrinsic limitations. I think it took near 30 years to get to where it's at. I think it's, and you can still hear on EMRAP, they tear up near on some of the methodology. It's been doing it for 30 years and the near registry still has flaws. We have to just slowly take steps to reduce our glaring flaws. And to me, the most glaring flaw is pain scores post-block.
Do you guys think having some kind of requirement to enter into the registry, like an order set or even just an agreement to a pre-made protocol, is that something that would be helpful to limit the fallout on the pain scores?
I think it's going to be very site dependent, Dan. Like I mentioned, I struggle with Epic power at my institution. And so I just, it's a Highland, they don't. So that works. I would love to be able to have the access. I just haven't figured out how to get my informatics folks to change things in a timely fashion. So I wouldn't put it like this is a requirement. It's like wonderful. I think I think it's great that we're getting the numbers, and like clearly we're catching at least some of the major, more near potential bad outcomes, right? I will be honest, I unlikely at Hennepin have been able to follow up a month out in most of my people, because that would be me going back and checking, and I just don't have time to do that. But definitely in the next, when the patient gets hospitalized or like the few hours. So there's definitely limitations, but I think the major bad outcomes we should be all catching.
Sounds good. Just for the
Dan,
sake
it
of time-
took us like, I am just finally, after a year and a half of working with our medical informaticists, just finally have like a raw post-block order panel that's going to go live hopefully in 2 weeks. But I think that's the other loophole there, is just how long it takes. So kind of building on Andrea's, but we have one that I'd be more than happy to share out with everybody so they could see it if that's an easier way to build it.
Yeah, I think having access to order sets from other institutions would be helpful. So just go ahead and send that to me, and I'll put it onto the main BlockHeads spreadsheet. In the interest of time, I'm going to let Tom take over and give his side of the presentation, and then we'll have additional questions after that.
All right, we're gonna skedaddle here. Hopefully you guys can all see the screen. Cool, good to go. All right, so let's go over some complications, things we kind of don't want to necessarily hopefully avoid, but we'll review some complications that you should be cognizant of. So particularly, we're going to focus on nerve injury, infection, and bleeding. We'll talk about a couple ways how to mitigate these, and hopefully give you some tips on how to, what do you do if you do encounter one of these problems. So let's start with infection. Infection post-block is actually almost like unheard of. So the big anesthesia literature with this French study, they looked at nearly 44,000 blocks. No single shot blocks had incidences of infection. And they were all catheter-related associated blocks. Now, interesting, when you do dive into this data, there's a hilarious number of case reports of people getting osteomyelitis from digital blocks, which I was like, that was not on my radar at all. So that was kind of interesting to note. Again, minimize your infection risk, right? We kind of talked about this on previous sessions. So just clean probe, clean cover, some type of sterile gel, and clean and prep the skin. So bleeding is the next one. This is another interesting one. That's rates in the pre-ultrasound era are still quite low and kind of very dependent on what you're blocking. So for example, things in the periphery were as low as 0.4%. And then when you tackle the axillary block using a blind technique, which again, I encourage you all to look at this because it's really entertaining how this was done before, was as high as 12%. And rates of the ultrasound area, this isn't described. So again, this would be something that our registry or Lachlan's registry and the company there would be something that we should just address, because I think it's an easy thing to grab. And the main complications you're going to see is actually nerve compression from bleeding around the area, maybe a hematoma. And again, you're going to try to obviously compress. You're going to obviously pick the right patients and try to avoid those who are anticoagulated and doing some of these blocks. So just be mindful of these ones. So let's get into the meat potatoes, peripheral nerve injury. Again, just a bit of a refresher on anatomy. The main thing we want to avoid is inadvertent entry of a block needle into the fascicle itself. So again, if you get it violate the epineurium, still not ideal, but not as catastrophic as entering a fascicle and potentially injecting into there. And so again, when we kind of look, remember, we always want to try to, Dan and Arun kind of speak to this of all blocks should be considered fascial plane blocks to really try to identify where those nerves live in their fascial planes. And we'll go over the importance of that in a second. But kind of the commonly cited classifications of nerve injuries, again, just for completeness sake, you get a bit of neuropraxia, which is kind of a focal demyelination. You get a little bit of defects, maybe some sensory deficits, and these usually tend to heal up pretty well on their own. You get I still have struggles pronouncing this word, axontomis. We'll just skip that. It's the second one. A little bit worse. Now you get a disruption of the axon and the surrounding tissue maintains intact. These ones are kind of dicey in how they repair themselves. Most of them tend to do well on their own, but some struggle. And then you have a complete neurotomesis, which is, again, complete transection of the fascicle. And these ones tend to not recover. And so when you start looking at this, it's actually kind of, again, a bit entertaining that there's not a lot of great evidence about this and what the etiology of this is. And we'll kind of dissect each one of these aspects of what potentially might cause these. So again, lots of theory, We think some things work and some things we know can cause it, but we're not really sure. So we'll kind of dissect each one. So the best from the anesthesia literature is the anesthetists like to blame the surgeon. So that's the best. So it's often cited that hip arthroplasty, for example, carries a 0.5 to 2% risk of sciatic nerve injury. And by doing a sciatic and femoral nerve block, that carries a 0.2 risk injury. So the take-home points from a lot of anesthesia papers is like, it's always a surgical cause, it's not us. Same thing for brachial plexus. When you look at shoulder surgeries, again, 4.3% in one study in 417 patients. So 18 patients had some type of nerve injury as a result after their operation. 2 they determined were due to the block, and the rest were due to the surgeon or being in traction for some seen amount of time during the OR. And again, it goes back to blame the surgeon, not the block. Again, using kind of what data we have, again, and unfortunately, it's not from our realm, but these are kind of the 2 biggest studies looking at anesthesia in an operative setting. So the group on the left's North American group with about just over 12,500 patients looking at their rates of short and long-term nerve deficits. And the short-term group was defined as less than 6 months, long-term greater than a year. And you can see for ones that we're commonly doing, it's actually the incidences are quite low. Again, the French one is cited as kind of being just because it's a massive paper and 44,000 patients. But again, their rates of peripheral neuropathy, cardiac arrest, and seizures and whatnot, again, very low in kind of the common blocks that were placed in their operative setting. So what are some risk factors for PNI? So again, needle trauma is a big one that is commonly cited, intraneuronal injection, potentially some neuronal ischemia, and medication toxicity. Other factors that can play a role, hematoma. Again, I'm going to argue that in the ultrasound era, I don't think this is necessarily that big of a role nowadays. Is there underlying nerve injury from whatever traumatic injury they've experienced or a type of traction injury? Or do they have an underlying pre-existing neuropathy? And again, this is picking that right patient. So avoiding the brittle diabetic person who's got horrific peripheral neuropathy, doing a block on those might not be the best person. And the whole notion is they've kind of coined this term of the double crush phenomenon. So again, you have a nerve that's already under some stress from either diabetic neuropathy or trauma, and now you're putting a block, whether it's a bit of pressure, a bit of ischemia from if you're mixing lidocaine with epi, for example, and then it's now got this double insult that'll raise the risk of nerve injury. And so let's kind of dissect this one by one. Does needle choice matter? So most of these studies tend to be animal-based, and they kind of found that the smaller angle beveled needles fared a bit better as the fascicles tend to kind of dive out of the way. And again, non-cutting needles tend to be our friend here. There was one human study out of France where they looked at 20 patients where they all got an axillary brachial plexus block. And I tried to do my translation with this. So it seems like they actually intentionally violated the nerve sheath, which was, I'm not sure how that got by ethics, but here we are. 4 out of 20 nerve injuries and 3 out of those 4 were resolved within 3 months. So again, this is direct violation with a needle, a bit of injection. And again, most people tend to fare well 3 months post block. So the take-home point with the needles, again, needle trauma, we think leads to injury, but seems to go away. Your needle injury plus injection is where you're going to get into trouble. So again, trying to identify that needle tip and making sure you're not within the fascicle is going to be your big problem. And this is kind of well documented within animal literature that it essentially destroys and shears the fascicle bundle. And again, you want to use the blunt tip block needles just to improve your safety, and it hopefully keeps some of those fascicles out of your needle trajectory path. What about resistance to injection? What's the deal with that? So again, the indirect sign is that your needle tip is now in the fascicle. And this is very subjective, right? So what I feel might be totally different than what Dan or Joe feels. And it's very dependent on your needle length, the syringe used, and how quickly you're actually applying the pressure to. This magic number of 20 PSI seems to have kind of been floated around. And a lot of this is based on, again, animal data. And they found that injection pressures greater than 20 pounds per square inch carried a high degree of risk of nerve injury, even with small volumes. And so then enter this, right? Is this going to make us safer by attaching these doodads onto our block apparatus where they kind of tell you, hey, you're injecting against a high pressure, you should consider redirecting your needle. And when you look at this literature, one, the people that have published on this, like the first author here, who we'll keep him nameless, a lot of this is funded by the companies that actually produce these devices. And the literature on it actually isn't that great. So I think the take-home points is commercial pressure devices. I don't actually think they need to necessarily play a role. I'm not convinced at this point based on the existing data. And talking to a lot of my local block colleagues in anesthesia, they've kind of taken the same approach. I think the big thing, if you're going to take one thing with the pressure, is actually do the first couple of cc's of injection yourself. So really get that haptic feedback of how much resistance and pressure you're applying to that syringe. And again, this is sometimes hard to do when you're doing these big blocks. But for example, one of my favorite techniques, this is one of my fellows doing a kind of this, I think it's described as a Jedi technique, where your needle's between the middle and ring finger. And then you're actually able to use your thumb as the plunger. So again, you're able to kind of get the sense of how much resistance is you're facing as you're doing your injection. So I say you be the judge, because I think you have a better feel of this. What about paresthesias on injections? So again, this is kind of that sensation that, you get that zinger down your arm. It's painless sensation distal to the injection point, and it's often thought due to the nerve is being irritated, whether from your needle or the poke. This is something that I hang my hat on quite a bit, and often ask my patients, let me know if you're feeling any zingers down your arm. And it's actually horrible in the literature out there. So only about 38% sensitive when they do appear that the needle was actually in the neural sheath. So bottom line is, don't rely on paresthesia. So the absence or the presence of it actually really doesn't mean a whole heck of a lot. But pain on injection is the big thing. So if there's any pain, severe pain that they're experiencing as you're pushing, that's a sign that you need to back off and check where your needle might have gone to. All right, neurotoxic agents. Again, local anesthetic with prolonged exposure can, again, it's theoretical that it can lead to nerve injury. Again, for us doing single shot blocks, I don't think this is really something we need to necessarily be considerate about. But the big thing is actually ensure that your anesthetic is preservative free. So I'm not sure why, but in my department, they have the glass vials of lidocaine and bupivacaine, and then they have these little plastic ones that actually have preservative in them. So make sure your anesthetic is preservative free. The preservative is well documented to be neurotoxic to tissues. And if you are mixing other agents in, like dexamethasone, for example, again, you want to make sure that it's without preservative. And does ultrasound reduce the risk of peripheral nerve injury? It's actually unclear. So we know ultrasound can identify intraneural injections with at least 1 cc. That's been documented in the anesthesia literature. However, animal studies show that peripheral nerve injuries can happen with a half a cc or less of injections. So maybe not so great. The problem with this data is, again, not to knock down any specialty or anything, but I think ultrasound was kind of put in a place and maybe used, and it's very operator dependent, obviously, right, as we all know. So I wonder if this maybe hasn't shown its true benefit just because it's in people who are still kind of maybe learning how to do ultrasound, and that literature hasn't really come out. There's no data looking at rates of vascular injury in the ultrasound era with nerve blocks. So I think, again, maybe idealistically, the ultrasound lover in me feels that this obviously makes us safer. But again, I think it's still a bit of an unknown. So hopefully the emergency medicine data can help us. And one thing I get our fellows and trainees to do in our staff is, once your block is in, actually go back and scan. So we want to make sure that that nerve still looks like a nerve and that it's actually bathed in anesthetic. And the reason for that is, one, it shows that you're in the right spot, and two, that nerve still looks like it's maintained. So we know we didn't inadvertently injure this. Compare that to this sciatic nerve. So the one on the left side of the screen is kind of the normal appearance of the nerve, compared to the one on screen right, which has been injected with anesthetic. You can see that it's completely just blown apart. There's no longer any discernible anatomy. So this is what you really want to avoid seeing. Rebound pains, this is something we don't really talk about. So that will kind of end the peripheral nerve injury, but rebound pain is something we don't really talk about. And even anesthesia literature is kind of new to it. The rates of it are unknown. The whole idea is that your block is worn off. The patients all of a sudden get this actually refractory pain that could be worse than their initial pain pre-block. I think it's something that we should probably be aware of, especially for discharging folks home. A couple of ways to mitigate this is add dexamethasone, either IV or with your injection, which has been shown. Fascial plane blocks, for reasons that are not quite clear, have far less rates of rebound pain. And again, also, one thing I do is just tell the patients to be on standard analgesics. So go home, your arm's going to be numb, but I want you to take some acetaminophen and naproxen scheduled, irrespective of pain or not. So just to be kind of prepared when the block does wear off, that you're on top of it. So take-home points, again, avoid PNI. It's pretty rare in the anesthesia realm, but minimize your risk. So pick the right patients to do these blocks on. Again, use the right equipment or right needles. Ensure that your local anesthetic has no preservatives. And again, if your patients experience any severe pain or high pressure against your injection, that's where you want to back off and reassess things. If you do encounter peripheral nerve injury, again, we'll talk a bit about discharge instructions, but when you are bringing these folks back, have some plan. So figure out at your hospital, it's quite variable. Our plastic surgeons actually locally, we have a couple of nerve repair specialists, and they actually want to see these folks. So they'll arrange their EMGs and nerve conduction studies, and we'll kind of take care of it. Other places I've heard they send them to neurology. Other places I've seen them sent to phys med rehab. So again, kind of check with your local institution what the practice pattern is and who you should potentially direct these folks to. Again, pointing to what Dan and Arun have said, all fascial plane blocks, treat them all like this. And I think that's such a smart, brilliant thing to do, is just get the needle away from the nerve itself and introduce your anesthetic as you're coming in away from the nerve, and just keep it as safe as possible. Avoid complications. Again, clean technique. I don't need to preach that. I'm still going to say use ultrasound because, again, in my head, I think this makes sense. And again, discharge instructions are imperative, right? So again, I'm in Canada, so the worst thing we want to do is block someone and send them home with a brachial plexus block for their upper limb injury, and next thing you know, they got frostbite because they can't feel it. So make sure the limb's protected. Go over thermal injuries at home with their, next to a stove or an oven, like simple things like that. And educate your patient about rebound pain, that this might happen. Here's a few ways we're going to mitigate this with some steroids and regularly scheduled pain meds as your way out. So, and again, going to the previous talk, can we provide this missing link now? And I think we can, right? I think there's a large enough group of us, and I think if we tag on a few more sites, that we can hopefully demonstrate that, one, we're doing this safely, but this is a safe procedure and does work quite well for our patients. So I'll end it there, and happy to take any questions.
Awesome. Thank you very much for addressing some of those holes in our understanding and concerns. Like you said, we'll open up to questions.
Awesome job. Thanks a lot. I actually was unaware about the dexamethasone for rebound pain. I mean, I think we all hear about it for the prolonging blocks, but yeah, in my quick review of just looking, they just published, I guess, a review article that looks at the incidence of that. So I guess it's one of those things to consider, but are there any potential, have you encountered any sort of potential downsides of the actual steroids causing some sort of actual inherent nerve damage itself, in terms of if we injure it, do the steroids itself impair healing of the nerve itself? Is that something we should consider as well?
Yeah, I haven't seen that. And I think the important thing is that rebound pain phenomenon and the steroid are, I think, two different entities. So the rebound pain isn't necessarily a result of a nerve injury. So it's kind of that more chronic, if you get the chronic paresthesias, that's where your nerve injury happens. And I haven't come across any literature for steroid use in those folks. From what I gather, why, sorry, and I got a junior blockhead here. The reason why you have nerve injury is also not well understood, and it's thought to be partly ischemic, inflammatory. So maybe steroids do have a role, particularly with the inflammatory aspect. So it's definitely one thing to consider. But yeah, the Dex was more to avoid or minimize the rebound pain once the block wears off.
Are you guys across the board then, I guess, for now, what we kind of opted to do dexamethasone for kind of prolonged blocks that serratus anterior, rectus spine, potentially, but we haven't across the board. I mean, I think there's a little controversy in terms of how well it actually works for prolonging the block, but now seeing this meta-analysis looking at this, I wonder if you all across the board are more likely to use that for this other phenomenon now, rebound pain.
Yeah, it's in my typical practice pattern. Again, if you're sending somebody home with a long-acting thing in place, I mean, I think it does double duty here, and that's kind of the approach we've taken on it as well. So, has anyone encountered a peripheral nerve injury? I was accused of one, so that was awesome. We did a brachial plexus in a remote setting. We went to go fly this guy out, essentially half of his humor sticking out, and he wasn't GCS wasn't quite right, and pressures were a bit soft, so we opted to put just a brachial plexus block and reduce his arm and fly him. And a few days later, you get the awkward, "Hey, do you remember that guy you saw?" conversation in the hallway. And so yeah, they're like, "Oh yeah, he's got this sensory deficit now of his upper limb." And I was like, "Oh no." Turns out he also had an inadvertent vascular injury that was distal to the block point insertion. So I actually went upstairs, and me and the anesthetist actually scanned his brachial plexus, kind of where I did the injection. You could still kind of see the entry point of the needle. And so the actual nerve kind of swelled up as he got closer to the actual injury site. So it seemed that he had a traction injury, just didn't manifest neurological findings when I met him. And then subsequently kind of had a delayed presentation. So again, whether the block, again, that kind of double crush phenomenon, you had an irritated nerve, and then I kind of irritated a bit more, but that wasn't super great.
Sorry to hear that. There was
Yeah.
a discussion from Block It Like It's Hot guys. I don't know if you guys listened to that that thing. They talked about how they're really trying to do brachial plexus blocks without entering the epineurium. And so they really don't like the superclav because it kind of requires that. And they're really favoring the Raptor and the infraclav because you can just get it around the fascicles as they kind of spread apart, rather than going inside that fascial sheath in the superclav area. So I wonder if that's
And their analogy, I don't know if anyone listened to that, but the analogy for it was hilarious. What did they akin it to? Is a bag of marbles, and you don't want to go poking into the bag and disrupt the marbles. And I'm like, that actually makes a lot of sense. So,
yeah, Tom, there's a couple great lecture. I think I use a multifaceted approach to thinking about P&I, and I think it's because obviously we're lucky our patients are awake. Anesthesia's patients are generally not awake when they're doing these blocks, so they don't know what happens, and the patient can't tell them what they feel like. So using pressure, which I think is, we had the pressure catheters. I used them for about 6 months. I hated them. They were really clunky and not useful. But just generally, if I'm able to tap, and I always use normal saline first, and it slides in very easily, I go forward. Also asking the patient if they have pain at the site, and if they have pain that's radicular. All those three things, and visualization, right? I never inject fluid if I don't see the fluid off my needle tip. If you do all those four things, I think you obviously don't get the chance to zero, but you actually are using kind of a layered technique to reduce your possibility. So I don't think you can say that, in my opinion, that if it's a 30% sensitivity, we shouldn't use it. And I know you still use it, but I think that using all those ways when you're talking to patients is the right way of doing this until we figure out another way that is 100% sensitive and specific. And the only, we've had two cases of it. One was a UC, it was actually, I'm not gonna name his name, but he was a ultrasound fellow back in the day who got a block at another institution, got a femoral nerve block, and had 8 months out, 6 months out, was unable to walk. He was unable to do other activities. He was able to walk and had a peripheral nerve injury. And that was done with ultrasound. That's the only person I've ever met. And he kind of walked through it, how terrible it was. But again, a lot of anesthesiologists back in the day, this is 10 years ago, would do blocks intraneural because they wanted onset time to be fast. I think the fact that I don't care about onset times makes me always think of this as a fascial plane block. Even if it's a femoral, fascia iliaca, whatever term you want to use, every block is a fascial plane block. Because my onset times don't matter. I don't have a surgeon on my back.
I mean, I do agree. I think with the superclav, it is a little bit harder if you're intramuscular. I mean, I think that onset, we've definitely have seen like delayed onset of the block, and that's where, I think I agree with like Arun. I think like just staying far away and watching your spread, but I could see why that discussion happens, because it's similar to the distal sciatic, right? Like those are blocks where it can be hard to actually get an onset of time if you're not completely next to the area and you're seeing intramuscular in the middle scaling rather than actually.
And the anesthesiologist, like Jeff Gadsden, cares about the surgeon. I don't care about, because once I think the Raptor is a safe block, but once you start letting novice people do it, you're going to have some error. And I think that what you can do with the superclav is just find the rib and do a gentle injection and make sure that there's no force and make sure that the fluid is tracking up. So I do think, yes, I would love to move everybody to a Raptor, but if I get my interns and second year student Raptors, I guarantee you'll have more error. And then that's the problem, right? So this is what I want to do is reduce error and get people comfortable, and then they can decide what they want to do. So I think that from their point of view, onset time is they care about it. I don't care. it's nice to have a quick onset time, but I really don't care.
Yeah, and I think being okay with the little bit of, a couple of cases where the musculocutaneous gets missed because you're not doing that upper fascial layer with superclav, it sounds like that's probably tolerable.
Does anyone use nerve stimulators?
That was literally what I was about to ask.
Okay.
No.
I've never used one.
I'm not aware of any emergency docs doing this, but that was another thing that, kind of, at least my view of it from the anesthesia lens was that it's kind of the gold standard. And even the literature for
But their
that was,
patients are like asleep and you used to not use ultrasound. I don't know.
yeah, no, I'm totally with you. But again, the nerve stimulator was kind of considered the gold standard for detecting nerve injury and when you're in the fascicle. And again, the literature behind it was all over the place. Like it's good, but not nowhere near perfect, right? And kind of to Arun's take on things is that's why they're advocating now that you should use ultrasound, a nerve stimulator, and a pressure detector, right, to really, really mitigate this. And so it's an interesting take, but.
I mean, I think it's like the divide is with anesthesia. When we talk to our anesthesia colleagues, they're still confused as to why we sometimes we do fascial plane blocks. Like they were confused about our fascia iliaca. They're like, well, you can deposit a lot less anesthetic if you just go right next to the nerve. And it's like they kind of miss the point of that. Safety for us supersedes. Like when I had discussions with some of the colleagues, and so I think that notion that simplifying less equipment, using ultrasound only, and staying away from the nerve, rather than the nerve stimulator and adding all these other complicated gadgets.
And I would also encourage you to ask them what their follow-up process is. That was eye-opening for me locally. So we were kind of developing our own protocol, how we're going to do this. And I asked for block guys, and they literally said, we rely on the surgeon to tell us if they can't feel a limb after the patient wakes up. Or the day after, I was like, what? So I was like, all right, well, I guess that's one way to go about it, but awesome, guys. All right. Anyone else have any questions, comments?
Yeah, and so I just one last point. So I think this leads back to your point, Tom. I think that if our anesthesiologists are not following up patients, the UCSF anesthesiologists are not following up patients, and nobody's following up patients, and we're actually looking at the chart to see errors and going through this in this manner, I think we're doing a better, and I don't mean this in a bad way, I think we're doing a better job than they are. So I think that is why the block registry is really interesting, and that's why the retrospective nature of it's fine for now. I think eventually 10 years from now, 5 years from now, maybe we move it. But I think that we have to recognize that they don't even have a block registry in America for anesthesiologists. We're the only group that's done it.
Yeah, and it's remarkable that you've gotten this number of patients in it in a relatively short amount of time, right? Like that French study, I think, if I recall correctly, was over 10 or 15 years, which is crazy. We also relied on anesthetists at like outside facilities essentially to call in and be like, hey, I did this, and this is what happened with this patient, right? So it's pretty remarkable the work you guys have done to get that up and running.
Yeah, so it's not perfect, but I think it's a good start.
Yeah, for sure.
Yeah.
All right. Shall we end it there?
Yeah, that's fine. I just want to give a couple of quick reminders. Looks like July 18th at 4 p.m. EST, 1 p.m. PST is going to be our next discussion. Arun and William Mason are going to discuss kind of focus in anesthesia and a lot of the kind of the trading back and forth that can happen between our specialty and anesthesia while they help us with our block startups and processes. We can help them utilize POCUS for a lot of the new problems they're seeing, the GLP-1s with delayed gastric emptying and gastric POCUS, and a lot of other variations of that theme. So we'll look forward to that discussion. Make sure you put that on your calendars. I'll put a summary out after this. Sign up for giving either a presentation or just lead a discussion. Like it doesn't have to be the level of presentation that these two docs have done, which has been wonderful. But just have questions that could spur a conversation on a topic that either you've run into personally or you have questions about. those types of discussions are super helpful, and we can put you on this schedule for a time that works for you during the next few months, especially going into the fall. Set up for the calendar, tell your colleagues, have them email me at dmersh@buffalo.edu, and then we'll see you guys in July. Have a great week, guys.
Great. Take care, guys. Good seeing y'all.